Pediatric Sleep Apnea, a presentation by Janessa McIver for TAPC 112. What is sleep apnea? Sleep apnea is a condition that affects respirations during sleep through physical obstruction of the airway or through brain differences that cause breathing to slow down or stop altogether. Children may have obstructive sleep apnea, which is the most common type, or they may also have central sleep apnea, a disorder of the brain. They may also have a combination of both. What are the various risk factors for pediatric sleep apnea? There are multiple risk factors that increase a child's risk of developing sleep apnea. These include enlarged tonsils and adenoids, obesity, craniofacial abnormalities, drug use, mainly sedatives, mucopolysaccharidosis, hypotonia and hypertonia, infections, upper airway abnormalities, gastroesophageal reflux, and a multitude of other metabolic and genetic abnormalities may be contributing factors. It is very common in pediatric apnea patients for them to have a high palate and a smaller oropharyngeal opening to the airway. Part of this is from the swelling from the adenoids and the tonsils. Another part are just the craniofacial differences that were mentioned. Is it common for children to have sleep apnea? An interesting study done in 2012 by the American Academy of Pediatrics states that 1 to 5% of children suffer from sleep-disordered breathing. Sleep-disordered breathing for this study included obstructive and central apnea, as well as nocturnal hypoventilation. Another study done in 2014, which was conducted nationwide in Canada, demonstrates a significant lack of resources and services for pediatric SDB, which is the acronym for sleep-disordered breathing, care across Canada, with pronounced geographical disparities. Even if only affected children in Canada were tested using polysomnography, the authors of this study estimate that there are approximately 7.5 times more children with sleep-disordered breathing than what they have current testing capacity for. A wonderful example of this is in Edmonton at the Stollery. There are 3 beds available for polysomnography testing. And our doctor, for example, that my son sees, who is a pediatric respirologist, has 5 spots available per month for her patients to use. So, seeing as how she has so many patients, that is a very small number of children that she can actually do the gold standard of testing for. Are there any symptoms that may indicate that my child has sleep apnea? What are they? The most common indicator seen in children with pediatric sleep apnea is snoring. Other physical indicators that you can keep an eye out for include restless sleep, night sweats, observed apneic episodes. A great way to check this: sneak in on your little one while they're sleeping, set a timer for approximately 5 minutes, and keep an eye on them. If you witness apneic episodes, your child will stop breathing in their sleep. Wetting the bed is another indicator that you may see. Daytime sleepiness, mouth breathing, well awake and while sleeping, growth disturbances, pulmonary hypertension, cor pulmonale, which is an abnormal enlargement of the right side of the heart, and differences in facial, nasal, and oral anatomy. Some psychological or emotional indicators that you may see can include aggression, learning difficulties, memory loss, headaches, problems concentrating, fatigue, inability to focus, and symptoms of ADHD as well as ADD. What happens if I suspect that my child has sleep apnea and I choose not to treat it? Pediatric sleep apnea affects every aspect of a child's life. If it is left untreated, the consequences can include failure to thrive, bedwetting, ADD or ADHD, various behavioral problems, learning disabilities, poor academic performance, obesity, increased risk of type 2 diabetes, language disabilities, including expressive and receptive, as well as pronunciation, and cardiopulmonary disease. Treatment of sleep apnea will effectively reduce related behavioral and learning difficulties. If a child has sleep apnea and it is accompanied by behavioral difficulties and the child is treated for ADHD or ADD, especially through medication, but the base physical problem for why the behaviors are happening is not taken care of, will the child ever get better? That's something to consider. What could my child's life look like if they had untreated